Oh, hey, Chris.
Hey Chuck, how are you?
I'm good. We're back together.
We are. You know what? I felt a little weird listening to you talk to somebody else for so long. I missed you. I'm glad that you and we had a nice time at the iFesh meeting.
We did. We had a great time, and yeah, did I kind of felt like I was cheating on you?
You know what? I think you will have a hall pass on this one to use some terminology. But I'm glad that we was able to help you out. It sounds like you had a great meeting.
Yeah. Is it IFEsh or IFSSH? I go back and forth, and maybe I should call it IFEsh. I don't know.
I think it's iFesh, but I find that some of our industry partners will call the hand society meeting ASH, and I
Right.
find that quite annoying because I don't think any
Me
hand
too.
surgeon actually calls it ASH, but I never correct them because it's not worth honestly, the energy. Because maybe they're right and I'm wrong.
That's right. I've thought the same. The meeting that shall remain nameless now was really, really good. I think it had good attendance. I wouldn't say it was great attendance, but it was good attendance. And there's something about a meeting that felt familiar because it was done in the style of a normal ASSH annual meeting. The venue was nice. The rooms could have been a little bigger. I mean, I guess I should be happy. All the sessions I was involved in had standing room only. Um, and having the international perspective and catching up with international colleagues is really special that you don't appreciate it until you have those connections and get to learn from your peers. It was great.
That's awesome. Everything I saw on social media was standing room only, so that's great. And I guess even if the meeting overall attendance number was smaller, at least maybe the meeting felt pretty big if people are all, jammed into rooms. So that's great. Everything I saw looked wonderful. Probably a good time of the year to be in DC in terms of the weather and everything. Hopefully you guys did you get to see some cherry blossoms and
Yeah, we did. My congenital hand study group met Monday afternoon, and then we went down to the tidal basin, saw some cherry blossoms. We were a little early. There were cherry blossoms blooming, but it wasn't peak. We had a little tour around the area. It was a little drizzly, which actually made it a little less crowded. I think the following week was the really busy week. We saw enough cherry blossoms. I have to say. DC is really an amazing town. It's a great place for a meeting, except for it's very expensive. But it's a great place for a meeting. And I neglected my children by not going there and having them experience all that there is to offer.
It's a wonderful place. I was talking to somebody else, I guess. Every time I go, I went and gave varying rounds at GW. Thanks for the invite, Sam Mogdeteri, a couple of years ago. And every time I go, I just feel like I'm in seventh grade. Because you should remember that feeling when you're on the school trip and you're looking at the Washington Monument, the Lincoln Memorial, the Smithsonian Museums, and you're on the lawn. And it's an amazing feeling. So I'm really looking forward to getting the kids there at some point. We should, in a future episode, talk more about your congenital hand study group because I think study groups like that are super interesting, and I think everybody understands that the congenital world is a small one. And that's been a long-standing group that I think has had a lot of impact, but maybe not a lot of people outside of the congenital world know about.
Yeah, it actually is a great suggestion because I think these groups run in different ways. It would be fun to talk about it, I think, and why it's so beneficial. Whether it's just age similarities, like surgeons of a certain age, or if it's specialty focused. I think there's benefits to both, and it's just a matter of how much time one has to commit to extra learning, so to speak.
Right, right. So, I remember when the study group was here in St. Louis, I think I was the fellow escorting people from the hotel over to the auditorium.
That was, I think, the pediatric hands study group, which is different.
That's different. There's so
It's
many.
different. Yeah, that actually is coming up very quickly. That's a United States-based surgeon group only,
Uh-huh.
and that is typically an annual meeting, which is another great group. It's a little different format. And now that group has gotten so large that we'll have 100, 150 people with interested surgeons and therapists. So it's just different. Our group we keep small, like I think you
Hmm.
keep your group small, just because it facilitates conversation.
Yeah, so we have our Planet study group meeting coming up next week in Chicago, where all the sites from our multi-center Plexus study come together, and that's a really fun meeting. We've done it every year. We've had the grant, so this will be the fourth year we're doing it. And we're getting together at the Hand Society offices. And we usually have a dinner the night before at at a restaurant close by in the West Loop, but we're gonna do the dinner at the Hand Society offices this year because of all the cool new games that they have on the second floor. So I know that you've availed yourself to those in the past.
Yeah, and hey, it's a benefit of membership where you can take advantage of the Hand Society offices, which none of us know about or do, and so I'm glad you are.
No, it's great. I mean, honestly, you think about like renting a room at any of these places, like running a meeting, the food bev minimums, the room charge. It's amazing the access that we've done. It so obviously Chicago is an easy place for a fly-in meeting, and it's a lot of fun. People love going there, and even better if you don't have to pay as much for the room.
Absolutely. Real quick, before we jump into content, did you have a good trip with your family to cause you to miss
I
iFesh?
I did. It was a wonderful trip. It's interesting. We're we travel a lot with another family here in St. Louis, and their older child is getting older and is going to be entering high school pretty soon. So the number of spring breaks that they have with him is getting smaller, and they're realizing that. And especially with sports and stuff, we're like, this might be one of the last couple of like 2 week spring break opportunities. So we could have this conversation another time too, but a 2 week trip is really challenging for so many reasons. But one of them is practice management. I remember when Rick Wright was still here in St. Louis, he talked about how he had never taken a 2 week trip until, I think his daughter was getting married or something in Australia, something. He went over there for 2 weeks and he's like, why didn't I do this more? But then everybody realizes that, when you take 2 weeks off, there's a number of things that you have to juggle and post-op visits, decrease clinical volume. And then you realize that why is my schedule looking so light in a couple weeks? It's because I didn't have those clinics to fill things in. So fortunately, I had a very busy clinical week in terms of getting people signed back up. But that is one challenge. But from a personal perspective, the trip was wonderful. We had a great time. 2 weeks is long enough, obviously, where you can actually remember that you're on vacation and can completely check out on all the other stuff, which is good.
Yeah, that's the beauty. I've never done it. And I do. I think it takes me 3 days to sort of get in vacation mode. And then a couple days later, I'm thinking about getting out of vacation mode, which is how my messed up brain works. So yeah, I think it's wise if you can pull it off.
I did think about you guys a whole lot, so.
That's a win. That's a win.
So we have our annual tradition of doing the What's New in Hand and Wrist Surgery from JBJS. We started this since we've been doing the pod, and it's amazing how the mantle has been passed on to somebody else even in this year. Sounds like Eric Wagner has taken the lead, and his partner at Emory, Nina Sue, they co-authored this year's edition. So we'll jump into that maybe for one or two episodes, and then before we do that, we should thank our friends over at Practice Link.
Absolutely. The Upper Hand is sponsored by PracticeLeap.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/the upper hand.
I love it. I love it. This is first of all, this is a meaty year in hand and wrist surgery guest editorial in JBJS. There's a lot here, which was sort of fun to read. I always learn things, and I do dive a little deeper for some of the topics.
Yeah, I definitely circle a few citations that I want to go back and read because I miss them. A lot of stuff like in the European journal, I just don't get to JHS Europe a lot. And we say this, I say this every year when we do this, but I mean, as much of a labor of love it was to do to write this article for 3 years, I was on top of the literature, which was great. So as much as I try to read everything that comes across my desk, I still like the paper journals because it makes me physically engage. So I have a stack of those over here. I just miss stuff. So this is really helpful. So thank you to Eric and Nina for writing it up this year.
For sure. I think we've talked about one of the things I do is to honor Paul Mansky, our former partner and one of my mentors. There is a Mansky Award, which is part of the Pediatric Hand Study Group. And so every year, myself and a couple others will review the world literature in congenital hand surgery. And it's super helpful for the reasons you say. And obviously, there ends up being probably 30 reviewable articles each year, maybe 40. And we pick a top 10 and pick a winner. And it's a great exercise. It's sort of irreplaceable to keep your finger on the pulse of what's going on in your area.
All right, I guess we have to come up with some kind of nerve award to give. Maybe
I
convince the
was
Hand Society to give us the time to do it.
I was thinking the same. I
That'd
was
be
thinking the
great.
same.
Again, it's one of those things where you keep yourself honest.
Yep. All right, scaphoid non-union seems to be the first topic.
Yeah, so I think this was interesting. I had to read some of these sentences a few times to really understand it. So, I guess one of the things that Eric and Nina jumped into here was, does healing the bone matter more, or does getting the alignment of the carpus matter more? And this seemed like a chicken or the egg kind of thing, but I don't know. Like, what's your take on these findings? Because, they looked at um, a study of 59 waist non-unions, and they were treated volarly with a tricortical non-vascularized graft. And the correction of alignment was only maintained in about half of the patients.
Yeah, whenever I think about this topic, I think about work out of Mayo with Linscheid and Dobbins suggesting that take down a healed scaphoid if you have flexion. And, no one would do that today. But this is really important. I would say this mirrors my personal experience. It doesn't matter how great my intraoperative correction of the scaphoid. And we should go for perfect. Like, this is not an excuse to accept less than perfect. But I think it's a reality that only 54% was there a sustained correction of carpal alignment. Um, Super interesting. And it had also indicated that carpal alignment did not correspond with union. Um, and so both really super important points.
So what's more important? I would think that the carpal alignment is the key to minimize the chance, because the whole end game here is to minimize the chances of post-traumatic arthrosis, a snack wrist. So is it more important to dial in the alignment and get that right, or is it more important to get the bone to heal?
Well, I mean, traditionally what we have been taught, and correct me if I get this wrong, is that, you need to have a reasonably well-aligned scaphoid or it will not heal. And that's why we talk about doing early surgery if there's a millimeter displacement. Well, flexion is displacement in a similar way. And so if we can, the goal is alignment to prevent future problems. But I've never seen a patient that has an increased intrascaphoid angle, i.e., flexion of the scaphoid, which corresponds with extension of the lunate. I've never seen that be a clinical problem. When we talk about snack wrist, we're just purely talking about non-union. And so healing to me is number one, ideally healing with restoration of scaphoid anatomy.
Yeah, I mean, I think that's well said. I guess I wonder when you're at least when you're in your own practice, like you just don't get the zoomed out view of how everybody else is doing. So, I have not noticed the malalignment to be an issue. It's mainly I think probably because I endeavor a lot to get that alignment as good as you can. So I think that's good teaching. But I mean, like some of these patients just don't heal. And that goes on to the next set of articles they talk about with using this LIPUS, the low intensity pulsed ultrasound. Have you ever dabbled with that for scaphoids?
Um, yes, like in a work comp population, in a professional athlete population, I think this is very helpful. The science doesn't support it up to now, and this new study does not suggest that there's any difference.
And this is your standard bone stim you would get off the shelf.
I think it is. Yeah, that's my assessment. I do use pulse ultrasound, so that's the one we have in the department that we primarily use. Yeah.
Yeah, I think it's been one of those things where my understanding and a very preliminary understanding of it was always that the literature didn't support it, but it made people feel better. And then patients oftentimes will come in saying, "Can I use something like this?"
Yeah, and my answer is if your insurance will pay for it, I'm happy to support it. If they don't, it's not inexpensive.
Doesn't hurt anything except your pocketbook.
That's right. And the other interesting thing is, it's a great, we all, here at WashU, we always try to have a group project going on. A long-term outcome of treated scaphoid non-unions, looking at things like interscaphoid angle by X-ray, probably, unless we get funding for CTs. It would be super interesting to build on this study.
I wonder what our volume is. Like we all, again, like we, as much as we are a group, like we all practice at individual sites, different days of the week. We barely see each other except for conference. So, I just don't know how many everybody is doing. So, I mean, if we have an interested fellow, I know some of the fellows listen to the podcast or an incoming fellow, we've got a project teed up for you.
This could be a great one. I would guess there's at least 20 a year, but you're right. It's hard to know, and the classic cut it, whatever a surgeon says, cut it in half, and then you'll have the
Yeah,
right answer.
you divide it by five, man. Like, everybody, you ask everybody their volumes. I've seen this. Obviously, with the research stuff that we do, you ask people who you think have a high volume how many they do, and then half doesn't do it justice.
Oh my God, too funny. All right, what about non-salvageable osteonecrosis of the scaphoid reconstruction? How do you think about this one?
Yeah, I found this, to be interesting. I think over and over, you're gonna find people that show that you can get stuff to heal without a vascularized graft, and then some people say you need a vascularized flap, so to say. So I don't know what to make of this. I don't think that this particular set of papers and their summary has changed my understanding of the truth.
Yeah, I
It's
think
as
that
muddy as ever.
it remains muddy. I did like this concept, and Marty Boyer and I were talking about a case. Um, Non-salvageable lunates with a coronal split fracture from Kienbach's disease using a medial femoral trochlear osteochondral flap, that's a mouthful, demonstrated promise with an over 90% union rate. That's super
Hmm.
interesting because I think that is a very tough problem, but you're going to have to work to convince me that's better than a PRC.
The coronal splits, I mean, that's a very specific but vexing problem. And that is something that will bring you to your knees if you don't plan for it.
Yeah,
Totally agree though. I mean, it depends. I guess, that we talk about PRC a bit later in this article, but I mean, that it is hard to beat the simplicity of the surgery as well as the simplicity of the recovery.
yeah, and to your point, there is literature out there that says just fix them. Actually don't. I have fixed my share of those coronal splits, and it just doesn't make sense. I've done it, and the patients have seemingly done okay, but it doesn't make any sense. Like that has no chance of healing. So why put a couple of micro or mini screws in there?
Mainly because you're making yourself feel better, maybe.
Back to the pulsed ultrasound.
Yeah, exactly, exactly. So yeah, no, I think that, the utility or the usefulness of these procedures. I think if you have, surgeons who are well versed in these techniques and doing them well, whether it's vascularized or non-vascularized, if you're doing good carpentry and plumbing, so to say, you're going to get a good result. And I think there's definitely some bias in what's reported here, like what makes it to the literature.
Yeah.
I still don't know I think it has to be either do what works in your hands or refer to somebody who has more experience with these.
I think that's absolutely right. And I think my personal practice, which is probably worth sharing. I take care of a lot of scaphoid fractures, acutely, subacutely, and non-unions. I love it when I can go dorsal. I do believe in a dorsal approach with the Joe Slade technique of placing bone graft through the drill hole. I absolutely go volar and use non-vascularized distal radius or tricortical crest. But if I think I need a vascularized graft, I call my friend David Brogan, and he's passionate about the vascularized grafts, and I think for some people it's the right choice.
Yeah, and I think that we're so lucky here to have a team of people that really are interested in very specific things, right? So that's a great example. And for in situations where I'm not sure what the right answer is, like you could go vascularized, could go non-vascularized, I'd rather leave that decision to the person who knows how to do both. And can count and has that experience like seeing people through both. So even if I'm not sure, it's like definitely a vascularized or whether it needs to be non-vascularized, I send it over to as I've called him in the past, my annoying cousin, David, and and they have that conversation because again, we're so specialized that it's nice to have somebody who wants to do that.
Yeah. So the next topic actually ties in really well with the IFESH meeting because scapholunate
I'm sure
ligament
this was talked about a lot,
a
and
lot.
it's a very international topic.
It's, I think, the most international topic. And I would say
Yeah.
this, as much as I enjoy wrist arthroscopy and feel like I have something to contribute, and I do a lot of it, I feel like our international colleagues are ahead of us for many reasons with wrist arthroscopy. And obviously that ties into scapholunate. And there was a lot of talk about SL injuries and appropriate treatments. I think this little section, which we can go through, captures it perfectly. It's 2025, and the discussion's the same as it was when I was an intern in 1996, and nothing has changed. The treatments have changed, but the outcomes are about the same. It's
So,
really fascinating.
so you were an intern when Michael Jordan was still with the Bulls?
and I couldn't watch him.
You didn't think I was gonna not pick up on that, right?
Well, here's a funny story. When I was an intern, I was telling this in the OR the other day. When I was an intern, it was back in the serious general surgery days, and we at Washington University were sort of influenced by the Duke mentality. And so that's when we wore all whites as intern.
Hmm.
Short white
Hmm.
coat, white shirt, white pants, and never to be seen in scrubs unless you were physically in the OR.
Hmm.
Crazy times. Talia found a
I
picture of me in my whites and sent it to me.
So I'd love to see that. First, that picture should go into, so make its way into the YouTube for the people that are watching.
No.
So when I did my residency at HSS, the part of the orientation packet was your short white coat and your two pairs of white pants. And the white pants had your name above the back right pocket. So somewhere I've never worn the white pants because there was no expectation that you actually wore them, but you had them. And then yeah, I think the HSS residents do long white coats now from the jump, but it was like a ceremony, right? Like you would go like when you became a chief resident, you would get your long white coat. And it was funny because in med school I had a long white coat, so I went from this long white coat in med school to the short, cute white coat in for 5 years of residence for me since I did a research here. And then the person that gave me because I did a researcher, the person that gave me my long coat was actually my original co-resident, Dr. Burks. So it was a fun picture of him giving me a long coat.
That's really funny. That's great stuff. Yeah. So, anyways, I don't know how I got us off topic. So,
1996 when you're an intern. So yeah, the conversation is the same. I was actually talking with one of our WashU colleagues, Mitch Pett. We were both kind of sad that we missed the IFESH meeting, and we're like, hey, they put it during spring break. Like, it's just for most American surgeons with young kids, that's a no-go. And he's like, you know what? I'm going to tell you the summary of the meeting. We still don't understand ulnar-sided wrist pain. We still don't understand SL ligament, and some people don't like nerve transfers.
that's interesting. I think I disagree with the first one. I think the understanding of owner-sided wrist pain, and I'm not picking on Mitch, but
Yeah.
and I think that probably is some people's takeaway.
Oh,
That's
neither of us attended the meeting, so this is just
right.
this is probably what happens
Oh,
at every meeting, right?
yeah. The SL part's definitely true. So this to jump into the meat of it, the controversy is as they say, the controversy is highlighted in a study of three common reconstructive techniques: dorsal capsulodesis, which I don't think many people are doing regularly anymore.
Not
Triligament,
enough. Don't
well,
forget,
maybe.
don't sleep on that technique.
The Brunelli triligament and bone ligament bone, a la Peter Weiss, and an average 9-year follow-up. Every technique had radiographic deterioration that did not correlate with functional outcomes. It's like it's a truism.
Well, so I mean, is it appropriate to take the nihilistic kind of perspective of like, why are we even doing this?
To me, like the most important thing is just preventing scaphoid flexion, getting back to the arthrosis discussion. I think that's the only goal. I don't care what the gapping looks like. And it's just so funny. These guys are up on stage and girls are up on stage and they say that and they all say we don't get x-rays after because
Yeah.
we don't want to see the deterioration, which is
Yep.
true, but feels somehow off.
But it's real.
It's
Yes.
definitely
I mean, so I remember, learning from you and Marty during fellowship. The whole game is avoiding scaphoid flexion. So every time I do one of these SL, reconstructions, repairs, because you don't know what exactly you're going to do when you get in there, I always leave myself the lifeboat of a dorsal capsulodesis because you know what? That's going to prevent scaphoid flexion at least initially. And I always want to make sure I have that available to me because I I can't say with confidence that these techniques are going to be able to achieve that goal. These newer techniques, and I remember writing this article 5 years ago, and it literally like the same type of conclusion from a similar type of paper, showing that none of these techniques actually, at least radiographically and in patient-reported outcomes, make a huge difference, or at least there's no superiority amongst the techniques.
It's funny. I've done a lot of these in the last few weeks. I think I've done four SL reconstructions the last couple of weeks, and talk about different techniques. One of the fellows, I'll leave him nameless so he doesn't get in trouble back at his resident institution. I said I was considering doing a front back technique where you sort of create a dorsal and volar ligament, and He's like, no, please, please, no. I've seen so many of those. They're torture. And, then you have the risks. Like, I think part of the treatment of SLs, you don't want to have a scaphoid or lunate fracture through drill holes, and you don't want to create a hugely stiff wrist necessarily. Because there's this one study of 21 front and back reconstructions, minimal 1 year follow-up, and it demonstrates promise. Absolutely. They all demonstrate promise until they don't. I hate to sound like I'm pessimistic.
Well, this is such a technically demanding procedure that once it gets out of the hands of the innovator, who knows? And I think that's what you saw with the Brunelli, and I think that's what you're going to see with the Anafab, which is what Scott likes to call his reconstruction. Again, in his hands. I think it's a very good procedure, at least what's reported here. I haven't personally seen him do it, and I haven't personally seen the patients. But I think once it gets out of the innovator's hands, that's the true challenge. That's something that resonates throughout all the different kind of innovations that we have in surgery.
It makes me think of a very prominent national hand surgeon had a sustained a distal radius fracture back in the early aughts. So I don't know, 2002, 2004, something like that, and flew to Miami to have Orbe do his volar plate, which at the time I was like, seriously, but probably wasn't a crazy idea for the reason you say.
Yeah, and I think there's something if you have the means to do that, great.
True, true, true.
It's a there is something about the because like how much Orbe thought about that problem, right? Like just the amount of nerdiness that goes into thinking about something where you're investing all the time to develop an implant or develop a technique. There's something about the understanding that that person has of the topic that probably isn't readily transferable to anybody else.
Yeah,
Um,
I know we're running short on time. Let's get through a very maybe the least important section, and then we can move on. Maybe we can talk about compressive neuropathies briefly.
but first, did you know that the Checkpoint Guardian nerve stimulator is not just for nerve nerds? Guardian is frequently used in other orthopedic procedures like distal and mid-shaft humerus fractures, forearm fractures, elbow fractures, revision elbow surgery for nerve identification and protection.
Visit.
I set you up so well. I read most of the copy.
You did. Visit checkpointsurgical.com to learn more or reach out to the Checkpoint team. And I told you before, I don't use Checkpoint very often, but I had a difficult case in a difficult area, and I did use a Checkpoint Guardian, and it was really helpful in trying to keep me out of trouble. So even a non-nerve nerd like me finds benefit occasionally.
In other orthopedic procedures.
Yes, exactly. Exactly. So the compressive neuropathy section is interestingly relatively brief.
So do you they go into here about, use of ultrasound and use of CTS6. Um, do you think that you can ever predict who is going to do well and, have surgical improvement, which is one of the things they looked at here, after carpal tunnel release? Do you base that off of, the things that go into the CTS6, anything you find on a nerve study or anything you find on an ultrasound, or do you just have this gestalt?
I think the gestalt for me is based on one thing and one thing alone, which is a component of the CTS6, which is night awakenings. And that I think if a patient has night awakenings that are classic for carpal tunnel, I feel really good about it. What about you?
Yeah, I totally agree because I think that is probably the one thing that you can make a big difference in quickly. Once the nerve has been compressed for so long and you pass the point where they're waking up at night and the nerve has burnt out, so to say, for lack of a better term, the cold carpal tunnel, um, it's damage control from there. And it's nice, like, there was a paper that we talked about in this session a few years ago showing that the nocturnal symptoms improve in the first 1 to 2 nights if this is the only reason that they're waking up. I usually tell people a little longer than that so as to look okay in terms of counseling. But I do say, like, if this is waking up in the middle of the night, within the first, few days, you might start to be able to sleep through the night. People love that. They're the ones that give you hugs when they come in saying, I haven't slept like that in years. And so I think I agree with that. I've never used the ultrasound to predict who's going to respond to surgery, but I never really thought about it that way.
Yeah, I haven't thought about it that way either. I certainly agree with your night awakening comments, and it's a beautiful thing when the night of surgery, despite surgical discomfort, they sleep better. I do think the other important thing, which we have talked about briefly on this podcast, is around amyloid. And I guess I'll ask you, how often do you biopsy? Do you follow the criteria of over 60 years for women, over 50 years for men with bilateral carpal tunnel? Do you biopsy?
I will shamefully admit that I do not think about this that much. Actually, before reading this article, this review, actually was talking to our resident, right, the chief resident of my service right now, Caroline Granger. I was talking to her about this exact topic because I was like, this is going to be a highly testable thing. Has it shown up on the in training yet? Because there's so many papers about it. That being said, I'm a hypocrite and I know the literature, but I still don't even think about this when I'm seeing patients. So you see so many patients with carpal tunnel, I just have not thought about it. And then when I read this, it made me think like if there was actual guidance from the Hand Society, I probably would do something. I probably would have to change either from the Academy of Orthopedics, the AOS, which does the CPGs, or from the Hand Society. I probably would change my practice. How about you?
Is it? Yeah, I do think about it occasionally. I have treated a couple of patients over the many years and that have ultimately been diagnosed with amyloidosis, and I wonder whether I missed an opportunity to diagnose them. But this number of 22.5%, that is the previous criteria, and if you add in spinal stenosis and cardiac disease, which really, I don't think we see all that much of, that increases the percentage of positive biopsies to 22.5%. So those four criteria, um, I'm sorry, age,
BMI.
sex.
Oh yeah, yeah, yeah.
Yeah, it's just age,
Bilateral
sex,
symptoms, if they're
bilateral.
over 60 for men, for women, and over 50 for men.
Right. And it's interesting. I think I'm going to probably start making that part of my practice and give it a run and see what happens.
Um, I'm gonna ask, I don't want this to be taken the wrong way, but if you do a biopsy, can you code for that in this context?
No.
And then where would you take the biopsy from? Because they talk here about you could do some flexor tenosynovium, you could even t send the TCL, which I had not thought about.
Yeah, I would presumably do some flexor tenosynovium. And I don't do endoscopic, which probably makes it a little easier. And part of this article refers to the success of endoscopic procedures, which is fine for those who are doing it. I think it's reasonable. I think it's pretty straightforward.
Okay.
I'll let you know
Um,
how it goes.
yeah, let me know how it goes. Like I said before on the pod that I did have a cardiologist come see me for carpal tunnel and specifically request that I send amyloid. And then the patient I saw this week in which we were talking about this, the patient already had amyloidosis and was coming in for carpal tunnel evaluation. So we were talking about the relationship there.
Yeah, super interesting. Well, this is fun. This is good for both of us. Hopefully, the audience enjoys it. I think this is usually one of our more downloaded and listened to podcasts. I think we have a fair bit to go. We may have to pick up the pace for episode two.
I think so. We always spend so much time catching up that we don't get a chance to actually get to all the podcasts. So thank you to those of you that have listened this far. Make sure that you send us any topic suggestions, handpodcast@gmail.com, and leave us a review on iTunes or Spotify. That helps us get the word out. And I did see one new review that we'll chat about next time we meet.
Perfect. Sounds great. Have a good day.
You too.